Thank you so much for joining us this evening. My name is Katie Vickery, and I am a program director here at the UAB School of Medicine. I will be moderating today's inaugural session of Mini Medical School, which is led by the Dean of the School of Medicine, Dr. Selwyn Vickers, and a panel of other key School of Medicine leaders. We'll begin with opening remarks from Dr. Vickers, and then we'll hear from our panelists. We'll have 15 minutes of question and answer time at the end of the session, and if you would like to submit a question, feel free to use the Q&A feature at the bottom of your screen. Thank you again for joining us, and I'm pleased to introduce to you Dr. Selwyn Vickers, Dean of the School of Medicine. Dr. Vickers.
Thank you, Katie. I'm excited to launch this mini medical school, and in part, for those who are on the call, I really want you to understand what I would call is America's hidden gem, and that's UAB Medicine and the School of Medicine. Partly because in any outstanding institution, it's not only buildings that make the institution great, it really is the people. And so through this process, I want to introduce you to a number of our faculty over time, but a key group of our constituents we'll share with you tonight. So as Katie said, I'm Selwyn Vickers. I'm the Dean of the School of Medicine. And for a number of years, I've wanted to start this program to really provide an opportunity for our community to understand the latest advances in research and clinical care that go on at UAB. I really want it to be an entry into our medical world without having to have an illness. I want you to understand the science and the individuals who we recruit here and the driving change they make, not only for this part of the country, but for all of our country. So you will learn from individuals who are really internationally and nationally known experts in their area. And they happen to be at UAB, continually fostering their careers while they also provide care for you as our citizens, but also in a process of discovering science and writing about that on a national level. In particular, I want to thank Dr. Herb Chin, the chair of the Department of Surgery, Dr. Sherry Cannon, the Department Chair of Radiology, Dr. Gina Marazzo, our Division Director of Infectious Disease, Dr. Sarah Nafsinger, a Professor of Emergency Medicine, and finally, Dr. Mike Sag, who's a member of the Division of Infectious Disease, head of our HIV program, and the Associate Dean for Global Health. This group is our mini medical school committee. They all have day jobs, but they've taken the time and effort to make this program a reality. And I really appreciate the time and effort they put in. So with that said, let me introduce the panelists for the day. We're fortunate to be hearing from some remarkable faculty members who are experts in the fields of infectious diseases, health disparities, and telemedicine. In our first panel, will be around infectious disease, and this will include Drs. Mike Sag, Dr. Gina Marazzo, and Dr. Sarah Nafsinger. I've introduced their role, but they have become most prominent both nationally and locally in the midst of the COVID-19 pandemic. These individuals have been a really critical part of our effort to fight COVID-19 and really key messages for UAB, Alabama, and the country. Next, we'll hear from Dr. Reagan Durant, who's Associate Professor of Preventive Medicine, and Dr. Isabel Skorinsky, who's Professor of the Division of Preventive Medicine, and they will speak on health disparities. The pandemic has, in no uncertain terms, made health disparities unbelievably apparent throughout our country, and including Alabama and the Deep South. They'll share of the impact and the challenges we face in moving forward. And finally, Dr. Eric Wallace, who's our Medical Director of Telehealth. Many times in crisis, there are things and activities that we will only learn how to do because we've had that crisis. Telehealth was around, but it has become central to how we take care of engaging patients. And Eric is one of the national leaders as he's helped grow this as a critical platform of how we take care of patients at UAB Medicine. Again, thank you all for being a part of this. As I said, there'll hopefully be many sessions to come. At the end of the session, there will be a short poll We'll want to hear from you to see what topics you want to learn about from our experts. Again, we hope you'll join us in the future to learn from our researchers, our physicians, and our faculty members who are changing lives of individuals, not only in Birmingham, Alabama, and around and our state, but around the country as well. Now I'll turn this over to Dr. Marazzo. Jeannie?
Thank you so much, Dr. Vickers. It's a really wonderful opportunity to be here. I can't believe that there are 84 participants in the chat. That's a lot of dedication for a Tuesday evening to come and hear us. So really appreciate everybody being here. I'm just going to kick off a discussion of the COVID response with a couple of words about our infectious disease division and what that was doing before the pandemic to make sure that we were optimally situated to respond. And just by way of background to let you know, I've been here for 4.5 years. I came here after a long career at the University of Washington in Seattle, very much to work with people like Dr. Vickers and Dr. Sag on this panel. And I came here to lead a group of about 47 faculty. And there were really 3 reasons that I came. And these 3 reasons to me are the backbone that constitute our ability to respond to the pandemic and to do it the way that we have. And so the 3 areas I'll just address very briefly are really what the division does, who are our faculty, and how we work. And so in terms of what we do, we are a very, very well-funded research division. We actually have over $30 million of direct funding a year in our division alone, which is a lot more than many departments have in many academic medical centers. So incredibly successful group of people, including Dr. Sag and others, who've managed to compete for successfully funds from the Centers for Disease Control, from the National Institutes of Health, and from industry partners. And when you look at where we have really led the field, it's almost prescient in that we have been leaders in the field of virology, particularly in HIV, but not just HIV, including CMV and other viruses. In vaccines, we have an Alabama Vaccine Research Clinic that has been at the forefront of doing research in not just HIV, but influenza, as well as other vaccines. And then also in advanced hospital care. So we work very closely with people who have patients who have resistant, antimicrobial resistant infections, complicated ICU courses, all that sort of stuff. And then the last thing that I would say has really prepared us in terms of what we do is our long experience working with vulnerable populations, people who are socially marginalized, underserved, and really our efforts to reach out to do HIV prevention, HIV treatment, very much led by Dr. Sag and his team, that's really prepared us to teach other people who maybe are not really aware of what it takes to do that and who are now being tasked with forming the COVID response. So being positioned to know Alabama in particular, to know the communities that need help the most pre-pandemic, and now knowing that they're the people who are really being disproportionately affected by the epidemic, has put us in a really, really good position to help people get this response together. The second thing is who we are. So probably the biggest reason I came, in addition to Dr. Vickers and the other leadership, was because the faculty in infectious diseases, and all of UAB really, but particularly my faculty, my people, are just some of the most incredibly talented, committed, caring people that I've ever met in medicine. And that's really saying a lot. And I say that because they're committed not just to research excellence, which you know from our procuring over $30 million of funding a year, but also because they're excellent clinicians. They really care for patients. And they're also committed to education. And when we think of education in medical school, we usually think of educating medical students, nursing students, allied health professionals. But I think one thing I hope you've seen during this pandemic is an incredible commitment to communicating to you, to the community, and to the public. And hopefully you've seen many of my faculty, and I am proprietary about them, on the national news, on the local news, doing webcasts, doing podcasts, just a very, very selfless set of people who I think are committed to making sure that a lot of the misinformation we've heard with this pandemic is dispersed, because it's really been tough to find trusted sources of information. And then the last thing I'll just say is the third area. So what we do, who we are, and how we work. Infectious diseases is an incredibly collaborative field. We work really closely with the pulmonary, the lung doctors who are taking care of the really sick COVID patients. We work really closely with the renal doctors who take care of patients with kidney failure. We are basically part of a multidisciplinary team that has to be collaborative and collegial and really have the patient first in their minds to provide really great care. It's one of the reasons many people go into infectious diseases, because people are generally really nice, they're really smart, they're really fun, and they really care. And so I will stop there, because I think hopefully that paints a pretty broad picture of why I think we were perfectly positioned to take on this really tragic occurrence, but hopefully meeting expectations in doing that. I'm going to turn it back to you, Dr. Vickers.
Dr. Vickers, you're muted.
Thank you, Jeannie, for that introduction and really highlighting the division and the work that's been going on even before COVID. Katie, is Dr. Nafziger next?
Yes, Dr. Nafziger, it's your turn.
Awesome. Thank you, Jeannie. That's going to be hard to follow. I'd like to start with introducing myself. My name is Sarah Nafziger. I am a UAB alum, a first-generation college student, and I came here for medical school and fell in love with it and never left. So it's a privilege for me to be able to continue to serve at UAB in the different roles that I fill here. I'm primarily an operational leader here at UAB, while Jeannie and Dr. Sachs, some of these other folks you're going to hear from today are gifted researchers and clinicians in other areas. I serve in a different way as an operations leader. A lot of the work that I do is surrounding emergency management and employee health and patient flow. So those are things that happen in the health system every day. So it's my job to kind of bring all these pieces together and help form them into a cohesive model that delivers the health care that everyone's accustomed to seeing. So I'm going to spend a couple of minutes telling you about the things that we do to plan for emergencies like pandemics. We really take, in our emergency management planning, we take an all hazards approach. And what that means is we really try to prepare for anything and everything that could come our way. Now, we've talked about pandemic planning for years. In fact, we've had some close calls in the past when Ebola came around in 2014 and 2015. We spent a significant amount of time planning for that and drilling and actually taking care of some patients who were suspected to have Ebola. So we learned a lot from that. Unfortunately, we never had to deal with the actual Ebola patient. We never had to face that here, but we were prepared to do that. So a lot of that work that went into that planning actually helped prepare us to deal with the pandemic that we're working with now. We also have learned from several other incidents. After Hurricane Katrina, nationally there was a push for all hospitals and health systems to implement something called the Hospital Incident Command System structure. And that's a model that we've utilized here at UAB very successfully. And it helps us organize ourselves in a way so that we can be functionally streamlined and so that we can communicate with other community partners such as emergency management agencies and public health agencies in a way so that we're speaking the same language. So those are some of the things that we do on a regular basis to prepare ourselves for emergencies like this pandemic. When we first heard about the COVID-19 virus in January and February, that definitely was not the first time that we had thought about how we would face a pandemic and how we would deal with it. One thing that I tell our medical students regularly when I teach them about disaster preparedness is that if during a disaster, if that's the first time you've met your local public health official or your local emergency management agency or EMS partners, then you're already behind in your planning. If you don't plan ahead and meet these other folks that you're going to be working with, you're already behind. Fortunately, that's something we spend a lot of time doing. We attend a lot of community meetings and participate in our local healthcare coalition. And those strong community partnerships have been critical to our success over the last several months. So I'm very grateful to have our community partners. So I want to take a couple of minutes to tell you about some of the specific challenges we faced, and then I'll turn the program back over to others. During this pandemic, one of the things that we found early on was that we were facing a national shortage of some of the PPE, or personal protective equipment, that we need to safely provide care to patients. So one of the things that we were able to do here at UAB, which I think is a really unique story that I'm proud of, is very early our professionals here who work in logistics and supply chain management identified that this was going to be a problem for us. And they started procuring supplies from alternate resources. And one of the places that they actually found, I love to tell the story, is there's a company in Texas that made chocolate candy, and they had repurposed their manufacturing process to help make some of the protective equipment we need. And so they were able to procure some of that from them and several other locations. So they've done some pretty creative things to help make sure we had the things we need to keep ourselves safe. Another story that's just, I have to share with you, it's just so amazing, is about our testing process here. You know, before January of this year, nobody had ever had a COVID-19 test or heard of it because it didn't exist, right? This was new to all of us. But the pathology teams here at UAB, our lab professionals and scientists, came together and just from scratch created a lab testing platform to test for COVID-19. And just, to me, what was just an amazing pace that they were able to implement that and deliver that to us when we were going to them and saying, hey, you know, we really need this so that we can deliver good care to our patients. They came through and delivered, and just, to me, what was an amazing pace. So I'm really just so honored to work with these people who are able to deliver on the things that we absolutely need to take care of patients. Lastly, I'll talk a little bit about employee health. That's one of the areas I'm responsible for, and I'm pretty proud of how we've responded to the pandemic. Our job is to keep our employees safe and make sure that they're able to come to work so they can take care of our patients. And so one of the things that we have to do in employee health is look at the guidelines that come out from the CDC, from the Alabama Department of Public Health, and Jefferson County Department of Public Health. And if you follow the news, you may have noticed that those change on a regular basis. And so keeping up with those and trying to integrate those guidelines into all of our plans and all of our policies and processes here is something that we do every day to make sure that we're in compliance with the latest recommendations. Lastly, I'll talk about just our plans for the future. You know, we have surge plans in place. We're worried about what might happen over the winter months with flu season. Are we going to have another surge in patients? So that's something we monitor very closely in the hospital every day. We're looking at those metrics and making adjustments on a daily basis to our bed planning and to all the things that go into caring for patients. And finally, we're planning for COVID vaccine distribution because we're hopeful that these scientists are going to be able to come through for us and come through with a COVID vaccine. So we're working on the distribution plans for that, which to me is the much easier part of it. I hope they can do the hard work and get us that vaccine in time so that we can deliver that and make sure that all of our community members have it. I'll stop there. Thank you for listening to my story, and let me share a little bit about what I do every day here at UAB. Thank you.
Okay. All right. Thanks, Sharon. This is Mike Sag. I'm going to share my screen. Hopefully everybody can see that, and I'll make it bigger. There we go. So as Dr. Marazzo said, I'm in her division of infectious diseases, and it's a great group of people. And I didn't think you'd want to leave a mini medical school lecture that had coronavirus in it that we didn't talk about coronavirus itself. So I'm going to talk about things that matter in terms of things you already know. You know to wear a mask, you know to keep distance, you know to avoid large crowds, and I'm going to give you some data behind that. First off, why do we want to avoid large crowds? This slide tells the whole story. Let me just walk you through it quickly. If we're looking at Alabama, this is a while ago when we had 39 cases per 100,000. Now we're more like 23, but for purposes of discussion, if there are 10 people in a room in this light gray, there's a probability that at least one person out of the 10 will be infected. There's about a 40% probability, 1 out of the 10. If there's 25 people in the room, the probability that one person out of the 25 will be infected is pushing 70%, and so forth. If there's 50 people in the room, there's over a 90% chance that 1 out of the 50, and if it's 100 people in the room, there's going to be a chance of about 98 to 99%. So when you hear people say avoid large crowds, these are the data that are supporting that. Now, right now, our numbers roughly about 20 to 22 cases per 100,000. So we're a little bit better than what Georgia was a few months ago, but we're not nearly as good as Vermont. So when you are thinking about planning a wedding or something else, and they say keep your numbers to 10 or 15, these are the data that we're quoting to make that point. Well, what about masks? Those of you who are about my age will remember this from Peanuts cartoon. This is Pigpen. And Pigpen always walked around with a cloud around him. Well, if we move that cloud up around his face, that's what happens when somebody has COVID. They are breathing, these small droplets are going into the air around them, they're kind of hovering. And that can go out to as far as 6 feet. And so when you say keep 6 feet of distance, that's because that cloud is here. Now note, if they're screaming at a football game or they're singing in a choir, that can be even further. And so when we wear a mask, we stop that spread from coming out of the person's mouth into the environment, and we can reduce that spread by up to 90%. So masks work. If this is now Pigpen here, I didn't mean to point to a woman, but if this is a person who's infected and she's breathing air out into the environment, this guy who's wearing a mask next to her is a little bit protected, but it's not good enough because the air can sort of come around the outside of the mask, and this person is at maximum risk. When the infected person's wearing a mask, note that the cloud is diminished in size dramatically so that now people are protected. And so that's something, when we say wear a mask, keep distance, avoid large crowds, you've just seen all the evidence. I can go into more detail in a different lecture, but this is the evidence. One other thing we're doing I wanted to share with you, on college campuses, a lot of you heard about a couple of outbreaks that have happened. Those are now back under control. And what we're doing is we're working with a large number, or maybe up to 40 now, it'll probably get up to 55 campuses, and doing what's called sentinel testing. And that means that we're on watch, we're on guard to see what's out there. And I love to think about the opening scene in Hamlet, where the sentry, the guy on sentry watch, the sentinel watch, is on the turret and hears the noise of the ghost of Hamlet's father off on the stage, and he turns to the audience and he says, "Who's there?" And it's the best opening line of a play ever, because you can think about it in terms of the ghost, but you can also think about it in terms of who's in the audience tonight. Well, in the case of COVID, I like to think of what we're doing for the campuses as we're that guard looking for this ghost, looking for hidden horror that could be out in the community, and trying to identify it and keep an eye on the numbers to keep everybody safe. And that program is called Guide Safe. You've heard a lot about it. Happy to discuss more, but that's something else that we're doing for our state and for our local communities that I think is very important. As far as the vaccine, the Russians appear to have one. We don't know whether it works or not, but we have a lot of vaccines and trials and development here at UAB, but also around the country. Those are going into phase 3. We're looking for safety and effectiveness, and that is really what's key. And we need to sort of wait for those data to come in. We're hopeful that the vaccine will work, but I will tell you, to temper enthusiasm just a little bit, I've been involved in vaccine development for HIV for over 30 years, and we've had some great candidates that had all the right stuff going into the phase 3s. They had immune responses, had everything we wanted. And Dr. Marazzo, when she was at UW, they were the center point. They were the heart of the AIDS vaccine effort. And despite all the good information, all the good data before we went to phase 3, we still don't have a vaccine that works. So getting out of the gate is one thing. Showing that it works is something else, and we need to wait for those trials to know the answer. Finally, I'll finish with something that we're struggling with right now. COVID itself is a challenge, and dealing with people in the hospital is one thing, but when people are through with their illness, there's a number of people who get what's called the long COVID syndrome. And it means that their symptoms can linger not just for weeks, but for months afterwards. And working with the pulmonary division, we're now setting up a long COVID clinic. We have another COVID clinic where people affiliated with UAB, be it the employee health group or people who have their primary care out of UAB, can come in and be evaluated. And this is something we're going to have to research and understand what happens that causes this long COVID syndrome. And it can be anywhere in the body. It can be heart, lungs, brain, kidney. And these are things that we're really kind of trying to figure out. We don't have any answers yet, and right now there's no specific therapy for it. So I think with that, I'll close and I'll stop sharing my screen and turn this back, the podium back. We'll hear about diversity. So Katie.
Yes, I'm going to go ahead and share my screen so that we can welcome our health disparities panel, Drs. Durant and Dr. Scarinci. And when y'all are ready, you can begin.
Good evening, everyone. Advance, please. So I'm going to be giving this presentation along with my esteemed colleague, Isabel Scarinci. We are both faculty in the Division of Preventive Medicine. Dr. Scarinci is a full professor of medicine and serves as Associate Director for Globalization and Cancer Disparities in the O'Neill Comprehensive Cancer Center here at UAB. I'm an associate professor in this, also in the Division of Preventive Medicine, and I also serve as Chief Medical Officer for Cooper Green Mercy Health Services Authority. We both do a fair amount of research related to health disparities, and we'll talk a little about health disparities through the lens of COVID-19 this evening. Advance, please. So one of the things that we wanted to talk about was testing in Jefferson County and ways in which our initial efforts globally in testing, perhaps we're not reaching every community locally. What you see on the left is a map of Jefferson County, and you'll see varying shades of green. I won't go into the specifics, but basically the darker the shade of green, the higher the percent of the population living in those census tracts, the higher the percentage of population living below the poverty line. So you can see that in essence there is this really linear track, almost completely overlaying the 2059 path through Jefferson County that indicates those areas that are higher poverty areas. And when we first started doing COVID testing locally, we found that the testing sites were not always in locations accessible to all populations. And as you might imagine, the folks who live in these high poverty areas probably have the most difficulty in terms of transportation barriers and other challenges in getting to sites. So if the sites aren't in their communities, they may be less accessible. We also found that quite simply, drive-through sites were not always amenable to those without cars. So if a stipulation of being tested is that you drive through with your car, remain in your car, and be tested while sitting in the car, if you don't have a car, obviously, that's not, the testing may be less accessible on that front as well. And then this last bullet, familiarity and comfort with a location is everything. So I think sometimes as healthcare providers, we can take for granted the difficulty that comes with trying to go get a test of any sort, particularly one with grave implications like COVID-19. And to the extent that it's already stressful and perhaps a difficult hurdle to make the decision to go get tested, having some level of familiarity and comfort with the place where you're being tested is everything. And certainly if it's a place outside of your immediate community or a place that you're not familiar with, that bar may, to go get tested may be even higher. Next slide. So in response to that, we have in Division of Preventive Medicine and under the leadership of Dr. Mona Fouad, who is our division chief and associate dean for diversity and inclusion in the School of Medicine, we have developed a plan to bring COVID testing to these local communities, not just to improve geographic access, but also to include an array of supportive services that might help to facilitate testing. And it's depicted in this schematic here on this slide. To the right, you see health navigator screening. So one of the things that we are planning to do with community-based testing is have trained laypersons serving as health navigators to do the actual screening. So these are persons who are trained to go through the screening questions and go through an algorithm to help determine, based on report of symptoms or potential exposures, who needs to be screened. In many instances, these folks may be better communicators of this information with potential patients than healthcare providers, simply because there's a level of commonality there. They're going to avoid technical jargon, and in many ways, they're more accessible by phone than the limited number of healthcare providers on faculty at UAB. We also want to increase healthcare access at large. So I've already spoken about the idea of increasing access to testing, but we also want to have the ability, once people become tested, if we learn that they are not engaged in care or have not established care somewhere in the community, we'd like to get them set up with Cooper Green, which is, as you know, the county-funded ambulatory care provider for the indigent and uninsured here in Jefferson County, as well as a increasingly large network of federally qualified community health centers. And then finally, the last aspect is phone-based coaching. So a lot of persons who are tested for COVID-19 also have a host of other chronic illnesses. And we know that those chronic illnesses oftentimes can make patients more prone to severe illness from COVID, but even outside of COVID, oftentimes people face risk from their chronic illness. And so we'd like to use this opportunity to engage people around coaching for self-care, for their chronic disease, helping to set them up with available services and patient education for self-management. Next slide. This is some preliminary, these are some preliminary results from our community-based testing, again, with in the Minority Health and Health Disparities Research Center. And this is data as of last week looking at positivity rates. This is a little over 10,000 tests. And as you can see in this bar graph, the total positivity rate was about 7%. But then when you look at the positivity rate according to race, down the fourth bar down, you look at the Latinx population, it's close to 20%. Among African Americans, it's about 9%. And then lowest among whites, a little over 4%. So you can see that the positivity rate is much higher in Latinx and African Americans and compared to whites, and this is reflective of the disparity that we see both locally as well as nationally with COVID-19. Next slide. And we also, Dr. Sag mentioned the importance of finding a vaccine, and this represents the next horizon as well in terms of health disparities. This slide looks at vaccination rates for pneumonia, and it's the vaccine is designed to protect against one of the most common bacteria that causes pneumonia, and it's a pretty well settled notion in medicine that adults over the age of 65 should receive this vaccination, and yet in 2018 you can see it among whites in that first ribbon in Alabama, only 76% were vaccinated. And this ribbon represents all states. And so you can see we're sort of right in the middle of the pack there, looking from the states with the lowest rates among whites to the states with the highest, moving left to right. However, when we look at African Americans, you can see that that rate drops down to 54%. And you can see we're in sort of the lowest grouping, farther toward the left, looking at all states. So again, we see this disparity for a fairly standard, uncontroversial vaccine that's been around for a long time. And it just highlights the point that when a vaccine is available, we have to make sure that we avoid these sort of pitfalls that lead to these gaps in vaccination rates by race to ensure that everyone receives the necessary protections for spread of COVID-19. With that, I will turn it over to Dr. Scorinci.
Thank you. Next slide, please, Katie. It's a pleasure to talk with both of you, and you can see why all of us are at UAB. We have amazing colleagues, very diverse environment, from basic to clinical. I'll be talking to you about the science we do at the population level. And what Reagan just addressed in terms of our fast response to COVID was not only the lab or the clinical, is how to reach the populations that we knew were experiencing high burden of disease. And we expected that the disparities were going to be there. And we know that what strategies that work for one group may not work for others. So my expertise, I'm a clinical psychologist by training, is develop programs that tailor to specific populations. And we immediately start getting mobilized on how we are going to reach African Americans and Latinx and the underserved, the poor, whites or other races that we knew they're not going to come to a central location. And we saw that early on and need to move very fast and tailor those strategies. So for instance, for African Americans, we have done a lot of, we consulted the community, we consult our partners. As a UAB, we do not do anything alone. We really partner with other community-based organizations that know these populations and get their input. So a simple strategy, yard signs work very well for African Americans. And then they said, well, we can do the yard signs for Latinos. And I said, no, that's gonna scare them to death. So we need to then develop very different strategies. And we partner with community-based organizations and build on our work that we have been doing in these communities for a long time. Because what I love about UAB and our School of Medicine is that we do not stop at the discovery, finding the tools, finding the vaccine, or I work a lot in cervical cancer. Finding the best screening is not enough. We cannot stop there. We need to get those tools and we need to get those technologies to the ones that need the most. And that is what a lot of us work every day and have that vision and the support from our leadership. For us in academic settings, one of the things that we value the most is academic freedom. And UAB is where we have ideas, we engage partners, and we go to the leadership, they say, go for it. And so that's what gives us the opportunity to try new things. As part of that, because of our efforts early on in reaching the underserved, the National Cancer Institute approaches for a supplement to understand the impact of COVID-19 in cancer prevention and control. For instance, we know that cancer screening is down. We also want understanding of people smoking more, smoking less, eating healthier. So, and then they ask us for UAB to lead 17 other cancer centers on this effort across the country to understand the impact of COVID-19 at the population level. So then we can develop strategies to address. We're going to see the positive and we may see the negative. I hope. I work a lot in HPV vaccination. I hope now that the population has seen the importance of vaccine. Maybe people are eating more fruit and vegetables now that they're home. But so then we are gonna identify that. We hope to have data in over 10,000 people in a very short period of time, so we can move very fast. And we are the coordinating center for this effort for the entire country. The other thing we have at UAB that makes us to respond fast is boots on the ground and people that trust us and we trust them. Our partners, our donors that trust us and to do the best we can to get those tools out there. We learn from our successes, but we learn even more about our failures. We have failed a few times and then we build on, and we know that trust takes time. And we can spend a lot of time here in terms of all of our experiences. I will highlight a little one as an immigrant, and when I came to UAB 20 years ago, and we saw the major influx of Latino immigrants to the state, and I want to do something about it. UAB was immediately behind it. And we established a program that now we promote breast and cervical cancer screening to Latino immigrants that are tailored to that population. But I'll save some for the questions because I think we're going to learn more from the discussion. But we want to give you a flavor that we work from the lab to the delivery, and we will make sure that we get everything to resolution, including the patients that Reagan mentioned. If once they are positive for COVID, they are our patients, and we are responsible to make sure that they get the care they need. Some have more challenges than others, like with me that I work with the Latino population, is when you live in a trailer, like we had one that the mom was positive, and we say you need to isolate. And she said, I live in a single wide with my husband and 6 kids, and I need to go to work every day. What do I do? And those are the challenges that a lot of times, we say about the isolation, we say about all these other strategies, but some of our residents in Jefferson County do not have that luxury, and it's on us to try to figure out with this lady what she could do, and we found it. She found a friend, and we helped them with groceries, and then she isolated in this bunkhouse of a friend in a trailer park. But those are things that we are facing every day, and that we are relying on each other. Thanks.
Okay, and Dr. Wallace, if you are ready, I will start your slides.
Sure. Well, first, I just want to thank everybody for inviting me to participate. I'd never been prouder to be an Alabamian. I was born and raised in Anniston, Alabama, and was really lucky to do almost all of my training at UAB except for my nephrology training. I did that at Vanderbilt and then very quickly came back. But it's really times like these that highlight why I came back, and it's because of UAB and what we have managed to do during a really tough time. So you can go to the next slide. So what I'm going to talk to you about is UAB and the telemedicine program at UAB and what it was pre-pandemic, and then what we've managed to achieve during the pandemic. So next slide. So really, what is telehealth? I think we all have versions in our head. Saying telehealth is kind of like saying healthcare. And there are lots of versions. In general, there's asynchronous telehealth, which means that the provider and the patient aren't talking in real time. So this is the portal message system would be an example of telehealth. E-consults is another one where provider talks to provider through a messaging portal, but they're not there at the same time. Well, most of what I'm going to talk to you about for the rest of this is called synchronous telehealth. So that's where provider and patient are on talking in real time. So either through a video visit or an audio only visit, like a phone call. So next slide. So where did UAB start? So when I came back from fellowship to Birmingham, like I said, I was lucky enough to come back home. Something just struck me about UAB, which is, how do you have a world-class institution in a state with some of the worst healthcare outcomes? And one of the things that kind of struck me as one of the biggest drivers of that is that UAB could only take care of people that could get to UAB. So there were geographic disparities. And I had a firsthand look at that because I did home dialysis and rare genetic kidney disease, specifically a disease called Fabry disease. So all of my patients were having to drive to see me. And one thing struck me was that for every patient that could drive to see me, there were probably 2 or 3 that couldn't, that needed someone at UAB or that level of care. And those were the people we needed to get to. So it turns out in the home dialysis population, I started a project because I told my patients that I think I could do this better over telehealth. Because they were driving so long to see me, that took about 2 years of regulatory, but finally got my first telehealth visit done about 5 years ago. And you can see in the background, that is one of our patients from Demopolis, Alabama, unfortunately deceased now, but was 92 years old, driving from Demopolis, Alabama, all the way up to Birmingham to see me once a month for her dialysis care. And that was the problem that I tried to solve with telehealth. Now, at the time, one of the things is that I got a grant to do this. There was no coverage of this in the insurance. So I could have done this anyway. I could have done it in patients' homes. I could have done it in medical facilities. But I went around to all my patients, and my patients were rural. The people I wanted to reach were rural, socioeconomically disadvantaged, and elderly. I mean, that was the population that could not do this in their home. So luckily, I went to Montgomery. It was the telehealth interest group, and there was always 4 of us that came. It was the interest group for the state, and there were 4 people that were always there. And I met a person at the county health department, Michael Smith, who let me use the county health departments. They were standing up telehealth or video conferencing equipment there. So I said, look, I'd love my patients to go to those county health departments because they don't have internet at their home. They don't have phones. And that's where we started. So next slide. So because of the fact that I never wanted to tell a patient because you don't have technology in your house, you can't participate, this is what we did. We got USDA grant after USDA grant. And actually, at the beginning of this year, 65 of 67 counties in the state had state-of-the-art telehealth equipment. The beauty of it was there were no disparities, which is that as long as you could make it to your county health department, you could participate in telehealth. And there were some other advantages, which is that you could do a full physical exam with stethoscopes, et cetera. But it was one of the largest telehealth networks really in the country. Next slide. The other thing that we did was we realized that we had to provide as much care into hospitals as we could. There's been dozens of hospital closures in Alabama in the last decade. 90% of rural hospitals in Alabama are operating in the red. So what happens in rural hospitals is that the hospitals, when they don't have money, they cut service, and then nobody goes to the hospital because they cut the service, so they cut more services. And eventually you get to a point where nobody's coming to the hospital because you have no services to deliver. So what we did was we partnered with Whitfield Regional Hospital, once again in Demopolis, who was our first site, and we started telestroke, telecritical care, and with the help of a company called Sanderling, started telenephrology in that hospital. So that's where we were, which was largely in medical facilities. So next slide. Now, unfortunately, about 2 weeks before the pandemic, I don't know much about China's healthcare system, but I know a lot about Italy's. I spent a lot of time in Europe, specifically in Italy and Spain, and those are two very good healthcare systems. So when I saw that Italy was going under very quickly, I knew that it was coming here, and there was really nothing that we could do other than prepare, that this hope and wait wasn't going to work. So what we did, we started planning very quickly because we knew that telehealth was going to be part of the solution. So next slide. So our telehealth approach to COVID was really threefold, which is number one, we had to provide as many services to other hospitals to ensure we had enough capacity to care for severely ill patients in Alabama. UAB was always at 99% capacity, so we weren't going to fit more people in UAB. So we needed to make sure other hospitals could care for patients without them having to come here. We needed to protect patients while getting them the care they needed. And finally, we needed a way for patients' families to see their loved one while they were in the hospital because we were limiting visitation. Next slide. So let's start with what we did to provide as many services to other hospitals to ensure that we had enough capacity. So next slide. So what we did was inpatient telehealth. We expanded telecritical care services to 2 other hospitals. We actually dramatically increased the number of telenephrology consults that we were doing, largely because COVID actually infects the kidney and caused a lot of acute renal failure. So in these 2 hospitals that we were doing nephrology, our consult volumes went way up. All of those patients, if we did not have those services, would have been transferred to UAB for further care, thus decreasing our capacity further. But we were able to manage these patients remotely. We increased telestroke, and thanks to the Division of Infectious Disease, we actually started teleinfectious diseases as well. The picture that you'll see on the right is a lady by the name of Kennedy, who was in the hospital in Demopolis for 38 days on the ventilator, being taken care of by UAB critical care docs 2 hours away. This is a patient that not only did she recover, during that 38 days, she got to be next to her family. I mean, otherwise, we underestimate the stress it is on a family to have to drive to UAB to see their loved one. There's a lot of uncertainty there, but this patient recovered because UAB was able to deliver care remotely. Next slide. So the second thing is protect patients while getting them the care they needed in the outpatient setting. So next slide. So what we did under this was a rapid implementation of telehealth. And I can't tell you how many people were involved in this, but we trained 2,200 providers. And it's important to think that telehealth is not just a video conference. We had to put in place all the billing, all the scheduling. We had to train the entire access center on how to schedule, all the docs on the ways to do a physical exam over telehealth. Before COVID-19, we were averaging about 3 telehealth visits a day, and I kind of chuckle now, because last year we did 1,000 visits, and the executive director of telehealth and I predicted we would have a 100% increase to 2,000 visits for this year. Well, I'm just shocked to say that today we found out that we have done over 200,000 telehealth visits since COVID-19 started. Next slide. So, and this is what happened. So if you look at the beginning of this slide, the red line is all of the in-person visits, in-person ambulatory visits. And what you can see is this huge decline, almost to about 33% of our pre-COVID volume. That's catastrophic, not only for our patients because we couldn't actually provide care, but also for revenue at UAB. What happened is, though, as that line decreased, UAB e-medicine was very quick to respond, and the first line you see going up is the green line. That green line is telephone visits. So almost immediately we had the process in place for our providers to actually start doing audio-only visits. Next, what you'll see is a slight rise in the purple line. The purple line is video visits. So shortly thereafter, the telephone visits declined and the video visits actually overtook the telephone visit as we could train more and more providers to do it. Now, what's shocking about this slide is that unlike other parts of the country who actually kind of peaked at about 25% telehealth and then dropped to about 8 to 10% telehealth, UAB has maintained about 34%, even as of last week, 34% of all of our ambulatory volume is going through telehealth, which is nothing short of a miracle. Next slide. So at one time, 72%, that was in April, 72% of all ambulatory volume at UAB was telehealth. Once again, that represents revenue to UAB, but more importantly, that represents patients that otherwise wouldn't have gotten care. Diabetes didn't go away because of COVID. Hypertension didn't go away because of COVID. CHF didn't go away because of COVID. And because of telehealth, we were able to care for those patients. Next slide. So the preliminary outcomes are very high patient satisfactions. We've looked at admit rates post telehealth visits, which are very low. So we managed to deliver care without compromising on care. Next slide. So finally, we needed a way for patients' families to see their loved ones, and probably some of the most touching stories with this. What we did was, since there was a problem with allowing visitors in to UAB, we needed a way for those families to connect with their patients, with their loved ones. And some of the best stories that we have is from palliative care, and palliative care has used this tremendously to really link patients with their loved ones as they are dying. You know, to think about families without this technology not being able to see their loved one just prior to death is just, it's really sad to think of. But not only we were able to connect one person with the family, we actually did family meetings at a time when it was critical for patients to see their loved ones because of how sick they were. Next slide. So to build on what Dr. Durant and Dr. Scarinci have said, unfortunately, just like I thought, which is that patients who are socioeconomically disadvantaged, if we were going to do this in the home, we were going to open up healthcare disparities. And unfortunately, this is a paper, this is data from UAB analyzing 130,000 telehealth visits with 77,000 individual patients. And this is what we found. Unfortunately, Black patients were 28% less likely to use video than Caucasians. Hispanics, so my mother is Chilean. I was born here, but my family is not first generation Alabamian. Hispanics are 33% less likely to use video. Age, so the older you get, specifically for every decade you age over the age of 20, you were 10% less likely to use telehealth. When I say telehealth, video. This is compared to audio or phone only visits. So 42% less likely if you were 60 to 69 and almost half as likely if you were 70 to 79. These are patients that need care and they need to be seen. They need the physical exam, but they were only able to use an audio only visit. Finally, socioeconomics play a role in your ability to use video. Medicare patients were 37% less likely and Medicaid patients were 55% less likely to be able to do video as opposed to phone when compared to those with commercial insurance. Next slide. So where do we go from here? Next slide. I mean, really, these are the actions that we have to take. So the first thing is telehealth is not a given in the near future. Congress, actually, we all talk about Medicare and insurance. In some situations, and this one in particular, Congress has to authorize the extended use of telehealth. Unless Congress acts to authorize the extension of telehealth, right now in October 25th, all of the visits done in the patient's home will go away. And that's a travesty for the work that everyone has put into getting this technology up and ready to really try and close the geographic disparity and delivery of care. We have to close the digital divide, and there's no question. So I was on the governor's task force for broadband, and unfortunately, a lot of that money, Alabama got $1.8 billion. A lot of that money that was earmarked for broadband did not go to healthcare. Now, it did go to a good cause in Alabama, but we still have a huge digital divide when it comes to healthcare. So UAB is partnering with Raziel Health. It's our remote patient monitoring platform. And now we have the ability to order a phone for patients that actually has video conferencing capabilities on it. And we're evaluating funding sources to actually get these phones into the hands of patients that need it for delivery of chronic care. The other thing is now that telehealth has, or now that COVID is starting, seemingly at least right now in Alabama, starting to decline, people are starting to be able to go back to facilities. So we are working again at re-implementing the county health departments and specialized telehealth hubs, so that for patients that don't have internet or a phone at home, they could once again go back to the county health departments, back to these ambulatory hubs to actually receive care. We need better diagnostics in the home. So what we largely did with telehealth was see a patient over a video conference on a phone, but we didn't have vital signs. We didn't have the ability to listen to heart and lungs. So what I'd love for UAB to be able to do is actually to really design some of these diagnostics and implement these diagnostics. One of the things that UAB has done recently, and it's scaling incredibly quickly, we went from 3 patients to 90 patients in a month, is the idea of remote patient monitoring. This is the idea that I send a patient home with a blood pressure cuff, a scale, a glucometer, and as soon as their data, as soon as they prick their finger and check their glucose, that goes directly into their chart. It's also reviewed by a group of nurses that calls the patient when those values are not what they should be. We're implementing this in the OBGYN population because Alabama has some of the worst infant and maternal mortality in the country, with the hopes that we can get a handle on diabetes and hypertension in those most at risk. And finally, inpatient. We have to get our rural hospitals the capital to start telehealth programs. There are many hospitals that we went to that wanted to start, but it's not a zero sum. There are some costs in order to start telehealth programs. So we have to get the hospitals the capital to start this, because otherwise it's a death knell for these rural hospitals. To lose service, you lose patients. You lose service, you lose patients. So telehealth is the only way these hospitals can afford service. But I think Whitfield Regional Hospital in Demopolis, Alabama really should be an example for all rural hospitals in Alabama. Next slide. So I just wanted to acknowledge the team. None of this can be done alone. We talked to the MUSC in South Carolina, and their e-medicine team has 40 people. This is our team. We didn't have time to hire a bunch of people when all this growth was happening. Luckily, we are starting to catch up, but an amazing amount of work went in with the executive director, the director of operations, our telehealth IT, in partnership with the Access Center, the MSO. But it's been truly amazing to see UAB be able to deliver this type of care and transition, I mean, completely redo and rethink how we can deliver care in such a short amount of time to reach that milestone of 200,000 visits. So, so really with that, that's the update. I'm extremely excited about what we've accomplished.
Okay, thank you everyone who participated on our panel. Really want to appreciate you taking the time out of your evening tonight to share with us. So now it's time for the Q&A session. So if you'd like to submit anything, please feel free to go to the Q&A button at the bottom of your screen and submit any questions. I did want to read a few comments that have been submitted during the session. One person said, I don't have a question, but want to offer a huge thanks to this entire team for their tireless work before, during, and after we are through with this pandemic. UAB Medicine has been the only source I have trusted and continue to do so. I have parents in the 70+ range, and my family is extremely thankful for our local UAB healthcare team. Thank you. And then there was one other comment that I wanted to share with y'all. So proud and ever grateful for UAB Medicine and the UAB School of Medicine. Incredible work by incredible people. Also, someone asked if this recording would be available after the session, and yes, it will be available. I will email the recording out to all the participants, and y'all can feel free to go back and watch this whenever you want. I'm gonna look at some of the other questions we're receiving. Okay, let's see. Dr. Vickers, I think this one will probably go to you. How has our training of current medical students, residents, and fellows changed during the pandemic?
So we've had to adapt like everything else you've heard. As soon as this was declared a pandemic, during the months of March, April, and May, our medical students, as a national standard, were not allowed to be in the hospital. So they were excluded from interacting with patients because as we were evolving in our understanding of the disease, we did not want to put them at unique risk of catching coronavirus. You got to understand, in which Mike and Jeannie can tell you, the concept of this being a novel coronavirus means that, number one, we had no test for it. We had no therapy for it. Everything we did was very much empiric. That is, we were learning as we went and as we would go to know how to take care of and support patients. So under that setting, we had to shift our training to be all virtual. We had to design cases, faculty to design cases, had divine lecturers to try and to implement training for our students who were no longer going to be seeing patients. In addition, we did develop a disaster curriculum. You heard Dr. Nafsinger speak about it, that we took that time to actually take advantage of this. We had our med students participate in call centers where patients were calling in asking, should I get tested? We had them also go through a direct disaster training module that we did in the context of work with Fort McClellan in Anniston in order to be able to actually have them gain expert knowledge about how to work and manage in disaster settings.
Thank you. For the COVID infectious diseases panel, just kind of a basic question. When do you see things possibly going back to normal? Do you all have any? I know that's probably your least favorite question to answer, but probably one that's kind of on everyone's radars.
Jeannie has the answer to that.
I knew he was going to throw me under the bus. Thank you, Dr. Sag. I guess I'm thinking that the best way to think about this right now is that the next phase is going to be a newer normal. Right now, we're in a weird normal that nobody is comfortable with, and we're all really tired of: patients, physicians, families, friends. I think that the next phase, really getting to where we can go out to eat at restaurants, go out to movies. I honestly don't think we're going to get fully there until we have an effective vaccine, and not just until we have an effective vaccine, which is why it's so important what our health disparities panelists talk about, particularly Dr. Skorinsky's work in HPV immunization. Until we have enough of the population vaccinated that we really do have effective herd immunity. And that's a really big holy grail. I mean, I guess in the meantime, the new normal is the most attainable near-term normal is to try to get to where many places in the country have gotten to, where people are comfortable eating outside. The burden of disease, as Dr. Sag noted, in places like Vermont is pretty low. I think we can aspire to that, and that would be fantastic. So I see it as a two-phase process in Alabama. We at least got to get to where the best states are, and we're not there yet. And then it's going to be widespread immunization and control. And I don't think that's going to happen until, I'm sorry to say it, but 2022. Dr. Sag, I would welcome your more optimistic assessment.
No, I'm afraid I agree with you, but I think that I would like to reemphasize one thing that Dr. Redfield, who's the head of the CDC, said this last week, and I think he was correct, that if we all would just commit to wearing masks, if 98% of us did that regularly, we can get a hold on the epidemic. That's been proven. And then when the vaccine comes along, then we can think about getting rid of it completely. But we can go a long way. And you see that when the governor issued the mask order back in July, it had a profound immediate effect within 2 weeks of the order. And now we're kind of letting up a little bit. We need to keep our foot on the gas. And what's happening in Britain right now, what happened in Israel, what happening in France, is that people got complacent and now they're seeing their cases rise again. That'll happen here too. So this virus is simple. It just wants to infect people, and it's our job to prevent it from doing that.
Thank y'all. Infectious disease doctors, y'all aren't off the hook. There are several vaccine questions. So I'm going to just read through a few more general vaccine questions and see what y'all have to say. Can you describe the general process for designing the actual vaccine? Do you think the vaccine will be multi-tiered, multiple vaccines over a period of time? With a vaccine on the horizon and implementation strategy, how will we plan to be successful considering some will defer or not want to vaccinate? And will the vaccination be annual or one time? I know that's several questions, but if y'all have thoughts on any of those, we'd love to hear them.
Well, maybe I'll start and then Jeannie and Sarah can jump in. So what types of vaccine? There's multiple. There's mRNA vaccines, there's product vaccines, there's live attenuated virus or chimp virus vaccines. So lots of different approaches, and like Tony Fauci has said, multiple shots on goal, and hopefully at least one of them hits. I'll also comment on how frequent will we, let's say we get one that's shown to work. I don't think we're going to get 100% protection. I think we'd all be happy with 50% protection, underscoring the need for continuing to use masks. But we do know that people who have been infected, like myself, a lot of you know that, we lose our immunity after about 4 months. A vaccine will probably have to be given at least twice a year. So it's not just the distribution one time and the production for 1 or 2 doses. It's going to be 2 doses initially probably, and then boosters every, I would guess, 6 months. And that's what we have to be prepared for. Dr. Marazzo, other thoughts?
Yeah, I think the question about, how often we're going to need to get vaccinated is a great one. People are really freaking out about getting vaccinated twice a year. And I think if we could do it more like the flu vaccine once a year, that would be terrific. I want to address the question about the implementation, because the CDC actually just released last week, the Centers for Disease Control, a really comprehensive, I think, thoughtful distribution plan for health departments to start working on. And one of the hot issues is going to be who should get first access to a vaccine. And I think we really have to think about this carefully, given who we're seeing have the most mortality and morbidity, right, from this infection. So the data that were presented by Reagan on who is most likely to be positive and who is most likely to die, those absolutely have to be in our first tier. Also healthcare workers, right? We cannot afford to lose any more healthcare workers to this virus. And then I think really vulnerable people, particularly in long-term care facilities, people forget that I think now, Mike may know, but 30 to 40% of the deaths in the United States have actually occurred in people living in long-term healthcare facilities. So it's a double whammy of being elderly and then being in a closed setting where you really can't get out, right? You can't isolate, you can't quarantine in a nursing home. So those are just some thoughts. And I just want to point out people are really carefully giving a lot of thought to what that's going to look like.
One of the other questions I just saw is about a vaccine program here at UAB, and Dr. Paul Gepford, our colleague, is running, I think there's 2, but Jeannie, do you have details on which ones are active now?
Yeah, I will just point out, I really am proud to say, more proud of Paul and his team than anything, that we have now enrolled over 20 people in what's called a phase 1 trial of the Sanofi vaccine here. Phase 1 means it's actually the first in humans trial. And this is a pretty exciting vaccine that a lot of us are really hopeful. I think all the vaccines are really interesting, but this is I think a pretty cool one. So we've enrolled 20 people here, and then hopefully if things go well, we will start enrolling people in December in that study in a phase 3 trial, which are those gigantic trials that are happening now for Moderna and AstraZeneca. We're also probably going to start enrolling in the AstraZeneca vaccine trial, but as you can imagine, just a lot of complexities.
That's the one that had the side effect.
The transverse myelitis, yeah, which we could talk about.
Do we know the status on PPE? Do we still have a shortage? Does the hospital still need mask and glove donations?
I guess I can take that question. Thanks for asking that. So actually the hospital is actually in pretty good shape for PPE right now. We have rented a 15,000 square foot warehouse in addition to what we normally have in our supplies, and have been working on stocking that in preparation for another surge should it come. So we have between 120 to 180 days worth of inventory in most of our major PPE lines. So thanks to our logistics and procurement professionals, we're in pretty good shape with that right now. So not specifically a need for us today, but there may be other ways that individuals could help if they so desire. But thank you. We're in good shape for PPE right now.
That is good news. Thank you. Dr. Wallace, I think this one is for you, and you probably won't be able to give a specific answer, but how much money is needed for remote monitors for patients? I know that people want to get involved and make telemedicine possible, and just kind of what do you see as the best way to support that?
Yeah, so the cost of remote patient monitoring, if you look at our platform, it's about $75 per patient per month. And then when you add in the nursing, because a monitor never saved anybody's life, it's the monitor and then interpretation of the data. So we have the bank of nurses that also look at that data. So now, fortunately, Medicare patient, it's actually covered by insurance. We're working on Blue Cross Blue Shield, and we have a great dialogue going to actually get it covered by Blue Cross Blue Shield, which leaves the gaps being Medicaid in our large uninsured population. So for instance, UAB partners with Cooper Green, and that would be a great population who not only could get benefit from the video conferencing device that comes, because the device that actually transmits the data is a phone with video conferencing. So if you order the whole kit, which is blood pressure, glucometer, plus the phone, you can do video conferencing on patients, plus get the data that you need to adequately address their needs. So I would say that's really it. It's $75 plus the cost of the nursing staff. And we have 4 million people in Alabama. Not all of them need monitoring. We have strict criteria in who gets monitored and when they graduate from monitoring. So many patients will only be monitored for 3 to 6 months, but some will be monitored longer, some shorter, if we can get their diabetes, for instance, under control faster. So that's roughly the cost. It's $75 per patient per month, and then the nursing staff is really what's needed to get this out into the underserved populations.
Thank you. Question for Dr. Scrincy and Drs. Durant. What is something tangible the community can do to help with health disparities, to partner with UAB? What can we do to help?
I'll defer to Brincy on that one. I'll add anything, but I'll give her first pass at that one.
Well, resources are always welcome, because when you go out in the community, of course, it takes more resources because we need to adapt, like Dr. Wallace talked about in terms of telemedicine. The other thing that would really help us is more racial ethnic minorities to come forward and be the spokesperson and motivate, because a lot of it is trust. I can say about the Latino population, why we're seeing it high, it's because they come in when they really have symptoms. They wait until the last minute because of fear, because of then I cannot afford health care. So that will really help us in terms of having people coming forward that have access to these populations and be the ambassadors, if you will. And we can train you if you have groups in your church, in your home, we can train you how to do it. But I think that is a major gap, because we are here and we are here to serve this population, but a lot of times it's getting to them and say, it's okay, we're safe, and we will take care of you.
Thank you.
And Katie can be a good contact, and then Reagan and I will train, and but that will really help us for them to come forward.
And the one thing that I would add is, we have tremendous amount of experience getting to these, reaching these communities and partnering with them. But we obviously are open to hear about ways in which some of you may have already established relationships, and particularly toward particular goals to provide services or that sort of thing. to the extent we can avoid reinventing the wheel and model things on existing collaborations or partnerships, we're very much open to that. So that would be helpful as well, just hearing about ways in which some of you, perhaps through your own organizations, have reached out to these communities.
Thank you. Let's see. This might be a question for Drs. Marazos or Sag or Vickers. Will personalized medicine play into treatments?
I can take a stab at it, although Dr. Vickers may want to go more into it because of his involvement in all of us. I mean, I guess one thing I will say is that, you know, we haven't figured out precisely at a genetic level, which is really where precision medicine is taking us, what predicts the worst outcomes with COVID. We know what the risk factors are, at least epidemiologically. Whether we can hone that down to precision medicine to help us direct not just treatment, but might it help us direct specific different kinds of vaccines for different populations? That would be really, really interesting, because as Dr. Sag mentioned, some of these vaccines use live virus vectors, attenuated or inactivated virus vectors. Others are genetic vaccines. So maybe there will be a role as precision medicine, you know, continues to rocket forward in helping us. But I would say that's aspirational right now. Selwyn, did you want to comment on that?
Jeannie, I think you're right. There's a lot that we don't know, and a lot of questions that we simply make sure we take care of patients. Obviously, 80% of people typically do fine with the COVID infection. 20% do poorly. And in just sort of blunt terms, we know that if you're older, you probably more likely fit into that poor category. But we don't know the biology completely and the genetics of why certain people do well and others don't. And as you've highlighted and others have highlighted, we clearly see disparities in the context of who died from the virus and who gets it. So there's a lot to be answered. The All of Us program, which has led the country in enrolling individuals to get their genome sequenced by the NIH, has also maybe the most diverse enrollment of any group in the country. And the NIH is now already beginning to ask, can we look at the individuals who've enrolled to get their genome sequenced and ask the question, have many of them gotten COVID and what has been their response? So to Jeannie's point, we're beginning to ask the precision medicine questions with the populations we have. And this is an area where Alabama can lead the country and the world of understanding the differences in how things may affect different populations, because we are a diverse community, but we also have an institution that has relationships of trust across the entire spectrum of our patients.
Okay, thank you all so much. Again, thank you all for participating tonight, especially at this hour. And I wanted to take a minute and put up a poll for those of you who are still on the call. We want to know what you want to hear about next. So if you'll just take a minute, you can cast your votes on what you'll want to hear next. Also, women's card is supposed to be women's care, so just notice that typo. Okay, great. I'm going to go ahead and end that. I just wanted to get an idea of what people are looking to learn more about. I know some people submitted questions about future mini medical school sessions, and we will keep you updated with those plans. You can look forward to emails from us, and our website here is go.uab.edu/mini medical school. And I'm going to turn it over to Dr. Sag to close us out.
Great. Thank you so much, Katie. And thank all of you for joining us. It's a real pleasure to have this opportunity to share with you what is happening here at UAB, and I'm especially proud of all the activities, but you got just a sampling tonight of a lot of what our esteemed colleagues are doing every day. I think we tend to take for granted sometimes the real excellence that's around us when we work at UAB, but I think what I'm most proud of is how we engage with the community. And I think this mini medical school program is really yet another example of how we really have this genuine partnership. And I think it's what makes UAB and Birmingham special. One thing, if you do feel so moved, you can go to the website and click. If you feel like you'd like to make some sort of philanthropic gift, you're welcome to. You can direct it to any of the 3 topic areas that you saw. And we'd welcome that, of course. There were questions about resources and what it takes. But what we really benefit from a lot is these donations that we can direct towards projects that we feel are important. And that's really fueled a lot of the research, but also the patient care and outreach into the community that we've done. This website, as you heard, is also where you'll hear more information. The question was whether this has been recorded. Yes, and it will be available to folks who weren't able to join us tonight. So thank you again for joining us. It's been wonderful to be with you. The time went by quickly, and I promise we're going to do many more of these, and your input on the topics will be taken to heart, and you'll likely see what you voted on coming up in a future mini medical school. Thanks very much.